Okay, we're continuing chapter 2. We are on page 26. This is the next part of chapter 2. We was at don't shout at the patient. Keep your pitch of your voice low. So if they're reading the lips, keep your hands away from your mouth. Use short sentences, simple words. Underline that. Short sentences, simple words. And repeat your words over and over if you have to. Sometimes they'll say, you just repeat your words. Picture cards that we just seen on, I want to say it was page 84. Wonderful thing. Sometimes they have speech problems. You'll just learn your patient. The more you're with them, you'll learn what they're trying to say. And you'll see, it's like they just don't know how to move their tongue because they can't hear what they're saying. So that's how
Have you ever
they
seen
talk
one
funny.
that could only say one word?
A patient? No, but I'm sure.
She can't say anything but toot toot. That's all she can say.
She probably could, hopefully she could think something else, but if that's it,
That's all she said for 3 years.
that might be it then.
No way they've done it.
Usually they come up with
Speech
something
therapy
else,
and all kinds of
but
things with her, but that's all
she got that
said.
down pat. Maybe that's all she remembers. Vision impairment. What are you doing? Can affect people of all ages. It can assist at birth or develop gradually, same as hearing. You can be born can't hear, or you develop it there. Vision impairment, if they have glasses, make sure they're clean, that you use the right stuff on them. Some are plastic lenses, they get solution or water. If depends on manufacturer's instructions. Try to make sure you know what they are. Some have a cleaning fluid instead of water, messes them up. Contact lenses, a lot of times they get old. They don't want to worry about the contact lenses. They get to wearing glasses only. That's because the contact lenses, you got to put them in first. And then, but they tend to just graduate at just glasses. Knock on the door, always identify yourself. Make sure that there's proper lighting when you're in your room. Make sure you don't talk to them like they can see stuff. This is saying this person is blind. Don't look over there or see that over there. You wouldn't say those things because they can't. Always tell the resident what you're doing. Don't come pulling on my clothes and you don't tell me what you're about to do. I'm blind, I can't see, and I don't know who you are. I think you need to introduce yourself, tell me what you're about to do. Use the face of an imaginary clock to describe things where you're at. When you walk into a room, usually I call that 6 o'clock. And anything straight ahead is 12. On this side is 3, 9. At 12 o'clock is your sofa, 3 o'clock, there's your bed. 9 o'clock, there's the bathroom or TV or wherever. You let them fill around. You let them use their stick if they have one. A lot of people get to know their room because that's where they live and they won't even need a stick there. Maybe they'll come use their sticks outside, but not so much. Okay.
I'm listening.
But that imaginary clock is how you describe things to them. Most of them get the clock. Do not move their personal items or furniture. How many times have you stubbed your toe just because something was moved just a slight little bit? And it really does happen. So you just do not move their things because they could fall, trip, and hurt themselves. Tell the resident where the call light is. Better yet, put it in their hands. Leave the doors open completely or closed. Why would you think that? Have you ever woke up in the middle of the night and you ain't really open your eyes? You just kind of go to the bathroom? And what if that door was halfway open? What you about to do? Whoosh, done did it. They either completely open or completely closed, not halfway, because that's what they're going to do too. They're going to assume the doorway's open or closed and hit themselves. If the resident needs guidance in getting around, you are to walk slightly ahead. Underline that. Normally, you walk slightly behind the person. For a blind person, you walk slightly ahead because you want to say, okay, step up a little higher, or there's a little bump right here. You want to experience it, and so you can tell them, okay, raise your foot up a little more, something like that. Encourage the use of their other senses. They get to touch things, feel around. Large clocks and clocks that chime. The city clock, the city bell. If you're blind, I don't know what time it is. Come 3 o'clock, it's gonna ring 3 times. And they got that in the nursing home too. They've got a big clock that rings, so those that can't see well, they'll know what time it is. Large print books, audio books, digital books, brailles. That does not mean they can't stop learning. They can't stop trying to use the brain. Get them some books online or however, but let them be read to them. If the resident has a guide dog, you do not play with it, you do not feed it, you do not touch it. It's their dog, and you can say hey, but they don't want you to get so friendly with the dog that they like you more than the patient. And that's half of it, and they've been trained to protect their owner as well. Mental health. Mental health is a normal function of emotional and intellectual abilities. A person who's mentally healthy is able to get along with others, adapt to change, care for yourself, give and accept love, deal with situations that cause anxiety, take responsibility, control and fulfill your desires and impulses appropriately. That is how an emotional, mental, healthy person feels. If you have the slightest little problems, you may not deal so well. A lot of times it's okay to be sad when you're sad. It's okay to be angry when people make you angry. It's just how do you deal with that? Do you go do self-harming things or harming things to them or things? That's part of your mental health as well. Underline, mental illness is a disorder. Excuse me. It can and will respond to proper treatment. In that mental illness, we can give medication, we can do therapy, we can try to change it. Even psychosis, we can give medication. Somebody who has behavior problems, we can try our best to fix that. Not always works, but it is a treatment for them. That's why you'll see a question that says, is mental illness like a physical illness? It is. We treat it, we try to fix it, and that's what we're doing. Mental disability is different. Can't fix it, but we can try to make it better. But mental illness, we're gonna treat it. And underline that where it says people who are mentally ill cannot simply choose to be well. We would like that. It does not happen, but that's that second paragraph, page 28, or first full paragraph. Don't talk to them as if they're children. Use simple, clear statements. Be sure what you're saying is what you're saying. Sit or stand in a normal distance. Me, I'm staying this far away. If they want to hit or act up, I got a little leeway on them. Be honest, direct, avoid arguments, and maintain eye contact. If they are combative, sometimes they're violent, hostile, but they may be hitting, pushing, kicking, verbal attacks. Sometimes they're just mean. It really depends on that person, but you do not still hit them back. You block your physical blows. You can do that. You can put your arm up. It might hurt them. It might, but as long as, you have, those are called attack wounds, not hitting them. There's a totally different order to it. But they can about tell whether you was hitting or they was hitting, far as the abuse. Allow them to calm down. If they're mad at you and they need help, you get somebody else in there. Don't just keep trying to help them. When they're angry at you, they may still hurt themselves or won't calm down. And sometimes you don't leave them alone. You never leave a confused or combative person alone. Even though they're confused and combative at you, you wait till somebody comes and then you get out the way. And sometimes it's just that today they just think it's you. You was the one. I used to have a Southwestern lady, and she wasn't all the time like that. But I must have looked like this lady that ran out of her husband's house. Because it was terrible, terrible words that she would cuss. She said, "You F Buck." And I was like, Buck is her husband. You Buck. So it was not me, but it had to be a trigger. I had to look somewhat like her. Because she wasn't always like that, but when she remembered that, she wouldn't let me have anything to do with her. And somebody else would have to take care of her. But that was... she was terrible with it too. I just had to go like, I was thinking about, who is he? But just watch that as well. Don't anger them even more. Don't aggravate them. When somebody's angry, you just kind of step back. That's the easiest way to do it. Don't aggravate them. Like something I would probably aggravate my child. but you do not do that to your patients. Be reassured and supportive. Consider what provoked them and try to change it. We call it what triggered them. What's triggered their behavior? What's triggered them to be mad? We remove that as much as we can and as easy as we can. And that's what we do. Always stay calm. Don't argue with your patient. Those are your guidelines. Trying to find out what caused them to be upset. Listen to them. If they're mad at you, you get out of the way. Answer the call lights promptly, even though they may be mad or angry. Still come at them. Make sure they're not in any danger. Stay at a safe distance. If they are being appropriate, a lot of times they're making sexual advances or taking their clothes off or doing all of the above. You let them know you can touch yourself. You can take your clothes off, but you're going to do it in your room. You don't do it, don't go down the hall. Yes, it's your right, but everybody else's rights is to have a not provocative environment. So you're going to your room. You can do whatever you want in your room, but that's where you're going. If they're naked walking down the hall, get a sheet, something, cover them up, walk them back down to their room. If they want to be naked, they can be naked in the room. Always remain professional. Make sure they may be doing this. You know, you think maybe they're playing with themselves, but most of the time they're itching. Something's hurting. Something's aggravating them. And that's when you do further assessments. And they may, there was a MR patient, mental disabled patient, who used to always touch on himself. But they would always try to keep in check because he'd touch on himself, or if it was hurting, he'd do the same things. But they had to discern which one was he doing. And they had to do that often because he would catch a UTI a lot. And but you know, he was at the point that whatever feels good, that's what he was going to do, and that's what felt good to him, and that's what he did. So again, you know, their patients, don't take it for anything. Make sure you are the comforting, kind person that wants to talk to your resident, or at least listen to your resident. If you have time, stop and talk to your resident. If you're in a busy way, try while you're in there helping them, talk to them. So you take two things and do it at the same time. Promote safety and handle non-medical emergencies. Now, some of this is what you probably already know about. How to pick up objects, how to keep your body in alignment, how to know your base of support and center of gravity. If you keep anything close to you, that's the best way for it to be. If you're out like this, that hurts when you're doing something anyway. Well, it doesn't mean I done got old, but back in the days, I don't know, but I do notice now when you do that. You don't twist in your seats. You don't twist when you're picking up a patient. You pick them up and you walk them this way. You don't want to, and I see it a lot, pick them up and then drop them down. You got smaller muscles on the twist. If you would pick them up, those are them good strong muscles, and walk them to where they need to go. And not necessarily walk them, but you face that direction. And that's going to keep those same good strong muscles instead of using those little muscles that you twist with. Those are the very things that you need to know. Body mechanics, know that definition, is the way the parts of the body work together when a person moves. Again, there's their alignment. Posture is there. Avoid twisting at the waist. Always keep your feet shoulder width apart. Underline that. That's maybe the most important part. Keep that shoulder width apart. And that gives you a bigger base of support and makes you stronger. And your balance is a whole lot better. Try to use your strong, large muscles in the upper thighs, upper arms, and shoulders. You're using all that, these thighs. And that's a bad way to pick up something. You're going to hurt your back. That just bothers my back every time I see that. Hold the objects close to you. Do not twist when you're lifting or moving. Always talk to the resident. Give them heads up on the count of 3. Even though this patient has not got much muscle power, some do. Allow them to help you on the count of 3. Maybe their legs don't even work. They're fully paralyzed, but their arms do. On the count of 3, they may hold on to you a little better, so you can get them to where you need to go. They may stand or try to balance on their legs. They're paralyzed, but they're still there. They can use them as a pivot point. But just know that give them a count of 3, so maybe they can help you in some kind of way. Underline, star, and underline again. Never catch a fallen resident. That sounds terrible, but you're not catching them. You allow them to fall on you is the other words that they should use. You are breaking the fall. You do not want them to go straight to a floor. When you see them falling, you don't catch them because that's going to catch that back muscle. I've actually caught somebody like that, and I felt it like it broke apart. But it didn't, or else I wouldn't be walking. But that's what it felt like. It messed me up. I still hurt there. But never catch a fallen resident. You are actually be there to break their fall. Factors that increase the risk of falls: clutter, throw rugs. That little rug right there, they probably wouldn't have in a nursing home because it moves around and you can trip on it. It's actually got the non-slip stuff up under it, but it's not so good. And they probably would get something else, a little heavier or with some better non-slip stuff. That's what you need even in your house and homes. So your stuff won't move around. Exposed electrical cords, slippery wet floors, uneven floors or stairs, poor lighting. Call lights that are out of reach. They say that's the most cause of a fall because they're trying to get help, but nobody comes to get them help. Next thing you know, they're going to do it themselves. Sometimes they're disoriented. Disorientation, know that definition, means confused about a person, place, or time. They don't know what's going on. They're disoriented. Guidelines for preventing falls. Again, clear your walkways of clutters. Use rugs with non-slip backing. Residents should wear clothing that's not too long. Some of this, is common sense. Answer call lights. Immediately clean up spills. Report handrails. Underline this: lock wheels and move footrests out of the way before helping residents into or out of wheelchairs. That is actually one of your state skills. You will be doing a wheelchair transfer, and you must lock the wheels and move the footrest out the way. The footrest can trip you and your patient, so move them out the way. And when you're picking them up from a bed, you would lock the bed wheels because you want to pick them up and you want that bed to still be there, or them to even use that bed as a pivot point too. They can lean, but if you got it unlocked, that bed's going to shoot out from up under them, and both of y'all are going to be halfway there, and maybe on the floor. So make sure you're doing all that. Get help with moving residents. If you don't think you can move them, get some help. Nowadays, they've got Hoyer lifts that are useful, and the littlest person is picking up the biggest people because they're Hoyer lift. As long as you can roll somebody, put them under a sling, roll them back, put them under a sling, you just put the sling on the Hoyer lift, push a button or pump it, or one of them has a big old pump. It really depends on all the Hoyer lifts that they've made, but they're very helpful. And you'll see once you get in there where you're needing Hoyer lifts, promise you're loving your Hoyer lift. Burns and scalds. We're talking about emergency situations now. Burns can be caused by dry heat, which is stove, electrical appliances, or wet heat. That's where steam. Those are terrible. But other liquids, all that kind of stuff will also, that's what they call wet heat. Underline, small children, older adults, or people with loss of sensation, such as paralysis or diabetes, are at the greatest risk for burns. You do not have very hot water around those people. A lot of times they'll even turn down their water heater so it can't get that hot. There was a young man, and he burnt, 70% of his body because he had fell in the shower. The shower was too hot and burning. And they said all that could have been avoided. They knew he was disabled, so just turn the water temperature down a little bit. But he didn't. As he fell, I guess he pulled where it was straight hot and burned him up pretty good. Scalds are burns caused by hot liquids. It takes 5 seconds or less for a serious burn to occur when the temperature of the liquid is 140. And most coffees are 160 to 180. So those can burn as well. I've actually got coffee burn. It's more like a top burn, but it's burn. And gotta be careful with your coffee temperatures as well. Always check the water temperature with a bath thermometer or your wrist. Same, you're gonna have to do a skill, several water skills, and that's what I call them. You're gonna check the water with your wrist. That's the best place to check water. And you're gonna ask your patient, will you check it as well? So both of y'all check the water, says okay, and that's what they're asking about, checking the temperatures. Always report frayed electrical cords. Pour hot drinks away from patients. You do not pour right in front of them because anything can happen. You can make a mistake. You've spilled things before. You don't want to spill on your patient. Make sure residents are sitting down before serving them hot drinks. That's what's next. Just like a 2-year-old toddler, what they're going to do next? Spill it somewhere. Not only for the mess, but so you won't burn yourself. Plate warmers. And the most one I think about there is like Applebee's, when they bring you that plate that's very hot after they just cooked something and it's still steaming. Kind of the same thing. And in some places they use a warmer, but it shouldn't be that hot. But you still don't want to set it anywhere on them or like that for it to burn them. Always keep hot drinks and liquids away from the edge of the table. Never sit it on the edge. Always sit it inside because that's what's going to happen next. So if you're sitting on the edge, what's going to happen? That's in the floor. Not only a mess, but could burn somebody. Resident identification. Y'all know the identify. You never do nothing to nobody or anything without knowing who that patient is. For nurses, it's major. CNA is major as well. You're going to have to chart on people. You're going to have to know what you did to whom. It's not everybody is the same. Everybody needs different things. You may like coffee, you may not like tea. And I served you a cup of coffee, I served you a cup of tea. And that's, imagine somebody might say they didn't get their coffee today. And you knew that, well, she didn't have coffee ordered because she likes tea. But that's why just little bitty things, identify your patients, know who you're doing, who you're talking to. Also, it might be on their wrist, archbold. They've got one you just scan. They've got some that's at their door. Most of the times what patients will do, and you got to watch out, they get into the wrong bed, especially your dementia patients. So try to get into their old room. I've seen this so many times. They're going down the hall. Their room is here now. But 2 years ago, their room was down the hall. I've actually seen 2 grown men literally fight because one's like, "That's my room." He's like, "No, it's mine." And he literally thought that was his room, and he was ready to fight. And they were fighting, actually. 2 old men, I don't know, 90 years old, fighting over their room. And we had to talk to him, and it took all of him to go to his room, to his real room, not his old room. So make sure you know who you're talking to, who your patient is, or else you're going to give the wrong care to the wrong patient because he was in that room until that man came back to his room. Hopefully no medications were given wrong, any of that kind of stuff. So you got to know, and hopefully you got a little scanner that you can scan your patient. That'd be nice. Choking. Residents with swallowing problems may have a special diet with thickened liquids to the consistency of nectar, honey, or pudding. Underline that. That's what happens when people cannot swallow. They give them nectar, honey, thickened liquids. Because if it is that thin, it's just going to roll right into their lungs. So they put a little thickness to it so it will stay where it needs to go. And again, that speech language therapist is the one who's going to evaluate that to see if they need any thickened liquids. And if you do have thickened liquids for your patient, you give them nothing that is not thickened. If it's water, you still thicken it. If it's juice, you thicken it. If it's orange juice, you thicken it. If it's anything, even medications, the little water we give during medications, that water is thickened. Or else they choke. So that is very important. Just know that. And you would not put a pitcher in their room full of water or ice water like you would every other patient. If they get thickened liquids, they do not get that ice pitcher. We still help them with their water.
How do you thicken water?
They've got a little solution. Just mix it with it. Yeah.
Sounds already freaky.
Yeah. It's weird, but yeah. It really depends. There are many harmful substances in facilities. So we don't want anybody getting poisoned. We're gonna lock that stuff up. Keep it out of the way. You can't say keep it high like you can for your children. We lock it up. Keep it behind some kind of door. Cuts and abrasion. Know what an abrasion is? It's an injury that rubs off the surface of the skin. A cut is a cut, and abrasion is the rubbing when you get rubbed, or like I fell when you kind of skid down. Those are kind of awful ones. Thinking back in the days, carpet burns. Anything that rubs, or you're doing something and you're skidding down and you didn't mean to, or it's some kind of hard surface that you scraped. But that's what an abrasion is. Also wheelchairs, and they know there's some stuff, they just put a lot of stuff in here. But wheelchairs, when you're using an elevator, make sure that when you push your patient in the elevator, don't have them staring at the wall. You want to turn them around so they can, wherever the exit door is open, where the place opens, you want them looking in it. You don't stand in an elevator like that, staring at a wall. Don't have your patient doing that either. You go in and y'all turn around so they can be looking out just like everybody else in the elevator. The Occupational Safety and Health Administration, who is OSHA, comes up with a book called the Material Safety Data Sheet. And each hospital has their own with their stuff that they're in, what their materials are, or their substances, their solutions, their sprays, their whatever. If it can cause poisoning, it's in that Material Safety Data Sheet. You can always look it up. Look up whatever it is. If it got in somebody's eyes, what do? Do we flush it, or we just close the eyes? Or do we need to go straight to the ER? Do they open their eyes at all? All of that is up on in that Material Safety Data Sheet. If you swallow something, what do? Drink the epic syrup? Sometimes, yes. Sometimes you don't do none of that. Drink some milk behind it. Drink some water. What do? That'll be in there along with all the other stuff. And a toll-free number to call poison control. You don't get your satisfaction. Fires. Hopefully y'all know about the fire. What is significant at nursing homes, sometimes they're still smoking. They need the fire-resistant aprons. And they are literally, this is like a tarp, but it's a fire-resistant tarp that goes across them. And if they drop something, it does not burn them. And they still, at sunrise, they still do smoke. They had quit them smoking, now they're back smoking. Because they call trying to keep them from smoking, but they'd rather keep them safe other than, they were going across the street, across the area, and to go smoke and rolling, getting over there because they're, smoking. Only thing I didn't like was this one time, and this lady stuck, and they actually had to put the cigarette in between her hands, and she was smoking. She barely had movement. Smoke it, get finished smoking, her little movement. They would take the cigarette, light another one, put another one in. That's how she smoked. If I can't pick up my cigarette, I don't think I need to be smoking a cigarette. That might have got them where they was at the time. But people are people. They got their choices, and they fought for that choice, and they let them still smoke. In case of a fire, make sure you know this acronym, RACE. Remove your residents first. What do you do first? Remove your residents, especially if the fire's right there. We're gonna remove the resident. Activate the alarm, contain the fire if possible, and extinguish. You got to know those. That RACE and the other one, PASS, has been on both of my RN, LPN tests. They don't let you forget that. All your CNA tests, it's gonna be there. That is safety 101. Know the facility's evacuation plan. Stay calm. You're not the one that runs out the building when they say it's a fire. You're going to make sure all your residents are out and that they are accounted for. Sometimes they assign people. You might be on the same unit. You got to get this side of the hall. You get that side of the hall. You get the fire extinguisher. You get the paperwork. You get the patients. You go outside, stand by the fire pole, and make sure everybody's accounted for. Everybody's got a job. But your first job is to make sure your patients are safe. I always say, imagine you got your blind patient running in the hallway. You got your patient who can't hear, they're still asleep in the bed. You know, everybody's running around crazy. You got people that can't walk. Do I put them in a wheelchair or do I just roll the bed down the hall? You know, you got to go through that and go through a scenario to help yourself when those things do come. Know what that PASS is as well. That's how to use the fire extinguisher. You pull the pin, aim, squeeze, and sweep. You ever seen like the hand grenades? They got a little pin, same kind of pin. What it does is it opens it up so you can mash it. And same thing. So you pull the pin, aim at the base. They want you to know the base because a lot of people just try to get the fire. But you aim at the base, squeeze the handle, and sweep back and forth. So that's how you use it. Sometimes they'll let you practice, and when we was doing ours at the job. But pull, aim, squeeze, sweep, and remove, activate, contain, and extinguish is your other one. Brace and pass. Brace. I think I asked you something about that. That's gonna be there. Pass, maybe. Know which residents need one-on-one help. Know who can walk. Know who's hearing impaired. I'm telling you, I can't hear nothing. The alarm going off, people hollering, screaming, getting burned. You know, as long as I don't feel nothing, I'm good and I'm still asleep. So you gotta make sure you get your residents. Remove anything blocking windows or doors, and that's always. You do not block doors, do not block windows because you may need to go out them. Don't use the elevators in case of a fire, definitely. Stay low in the room. If the door is closed, check for heat coming from it. You may be in that situation. I hope never to be there. But if so, I'm plugging all the doors. I don't care what I got in there. We got some pads. We got something we can wet and stuff the door so the smoke won't come in. Smoke starts coming in. We got one for the face. If we have to jump out a window, I would never work in a 5 to 6 story nursing home. Because we're going to have to get the patient. How are we going to get the patient? I'm going to get out. How are we going to get your patient out? And then we're trapped in a room.
I was just about to say, how are they going to get the people that's at the top down to the bottom if they can't use the elevator?
Yeah. That's the way. We got to go use the stairs. And you taking all, imagine 6 floors of people trying to take the stairs. It happens. It just happens in big cities all the time. Fire alarms go off and everybody's racing down the stairwell and you got 1,000 people getting run over. You got babies. You got everything. It happens. And if you ever been in a high rise and the fire alarm goes off, they evacuate that whole building. So nowadays they've got things that you can go to the floor and it's like a slinky. Looks kind of like a slinky, but you go in it and it just slides you right on down. You slide. You actually kind of feel like you're falling, but you're sliding down the building or down the side of the building. But it's holding your body where you're not actually falling. You're sliding, just like you was on a slide. But it holds you. They got that, and you want that in case of fire. I want it because I know how I've been there one time with them evacuating and how the stairs look because everybody's taking the stairs because they don't want to take the elevator because the elevator starts working when a fire reaches the electrical system. It's gonna stop working and then you'll be stuck for real in an elevator burning to death. That's why nobody wants to get on the elevator. You don't get on the elevator in the fire. You don't want to. I don't care if you think that's gonna make you faster. Maybe some people would still do that and still think they can climb out the elevator. You know, at least I got to the 2nd floor before it went off. But, you know, I don't know. I think I go to the top floor. I don't know. But, I don't know. Maybe the helicopter gonna pick me up. I have no idea. But, know your facilities policy on fire protocol. Know where you live. You should know that in your home. Everybody should have some contingency plan in a window so they can jump out of it. Those type of things. Know your disaster guidelines. Know that stop, drop, and roll if you do catch fire, anything. Stop, drop, and roll. Throw a blanket over somebody if it's not you. and you tell them to stop and roll and throw a blanket over them, throw your jacket, something that will get the fire, cover the fire. During disasters, a nurse or the nurse administrator will give directions again. Yes, there is a fire. No, you do not run out the building. Now, if I went to Walmart and they said it's fire, I'm running out the building.
Yeah.
Anywhere else you work, you're no longer that person who runs out the building hollering and screaming or whatever you might do. You got to look out for your patients. Demonstrate how to recognize and respond to medical emergencies. First, you always assess the situation, then you assess your victim. The situation, is it safe for you to get there? If it's, I don't know, gas coming out of a gas tank, I'm not coming. I'm going to talk to God, and I may still do it. But it's going to be something that is split made, and you're trying to help somebody. But you also can get blowed up yourself. So watch. Make sure it's accessible and that you can take care of that. Assess the victim. Are they conscious? Are they not? If they're not, you want to just assume they're giving you permission to save my life. If they are conscious, you ask them, can I help you? If they say no, you don't help them. This one person actually, and they was big to do about it because he did not, I don't know if it's a white or black person, but it's a different race. Or could be Indian, I don't know. But he did not want that person touching him, but he needed emergency help and refused. And almost died from it. And just, I guess whoever it was that was trying to help him, they got big coverage because, they're trying to help somebody. But you don't help nobody that don't help themselves. But when he fell out, he had all the help. It didn't matter after that. But he was like, it was saved. Anytime you would consider implied consent, say it was your child and they're on the playground, you're at work, yes, take my child to the ER if he's broke something. You have my implied consent. You have my, probably done got a consent, if it's school, but help him out. Any severe bleeding, change in consciousness, irregular bleeding, swollen places on the body, medical alert tags, anything the person says is painful. Sometimes you are the only person that gets to see that person while they're conscious, because maybe they're bleeding to death. Maybe they're not going to die, because you can lose a lot of blood and still be alive, but you're going to fall out, and your body kind of slows itself down, and you may be the only person, and I've actually been in that situation. A lady fell out, and hers was, she was just in so much pain, she couldn't take it no more, and she just blacked out and was gone. But I got her cell phone. She handed me her cell phone. She told me her son was somewhere. I can't remember, but that, you talking about, that was crazy, because she, one of my students was going to clinicals, CNA clinicals, and they had already, not my students, but a student passed by and came, said, there's a rake down there, and there's nobody helping them people. And I don't know where in me, I just got in my car and went to go help. And that's as much as I got from her, and then she fell out. And it took a little bit for the ambulance to get there. It really did. But the lady was still breathing, and she had a pulse. It was thready, and it was getting faster. The less blood you have, your blood tends to beat faster, which is crazy. But it's trying to get oxygen where it needs to be. But I don't know the end of that story. They wouldn't let me know who. It was a issue with privacy and stuff like that. So, I don't know, but I know I did my part and tried to get her family there, anything. First aid is emergency caregiving. First aid, something's happened and you're there. And CPR is the best first aid. If I'm out, please try to restart my heart. But that is cardiopulmonary, cardio meaning heart, pulmonary, lungs. That's your CPR. Underlying brain damage can occur within 4 to 6 minutes, and you can die within 10 with no oxygen to your brain. Brain damage, 4 to 6 minutes, and you can die in 10 minutes. So we need to get that blood flowing. At least it may have some oxygen left in there. Even if you're not breathing, we're going to try to keep that. You haven't used all your oxygen in your blood, so we're going to keep it flowing. If you're not certified, do not attempt to perform it. Know where you're at. Some facilities don't want the CNAs to start CPR. They call the nurse, but Most of them is going to tell you to start CPR. If you got your CPR card, you start. If you don't, you holler for help and you pull the first person that you can, because you don't want to get in trouble at your job either. But that's another reason why everybody studies CPR, mostly in healthcare. Choking. You know what choking is? What's the universal sign for choking? What you gotta do? If you do anything else, nobody's gonna know what you're talking about. I'm choking, or something. You're choking. Something, you're doing this. That's the universal sign. In order to get the fastest help, that's what you do. I had a young lady acting crazy. She had lost her mind. She was choking and running around. Running. When I finally figured out what's wrong with her, I was like, God, I would not have wasted. I would have sit real still. To preserve all my oxygen. I don't want to run it out. But she had choked on a blueberry muffin. And that's all it took me when I figured out what's wrong with her, because she ran past and ran back. And one time she was like, I was like, so I said, trash can, you need to throw out? And she was like, no. And she ran. And something just made me say, is she choking? I'm going to, if I don't think you understand what I'm talking about, I'm going to take you, I'm going to stand in front of you, I'm going to put your hands around me, and I'm going to tell you, let's do this. Help me out.
Yeah.
And, but anyway, it took two little things that blueberry muffin came out. It was dry. It was dry, and it got stuck. I mean, that's as much as it can be. That kills you. But she was slobbering so much, I think her body would have eventually just slobbered it out of her. Or she would have got pneumonia from it going down the wrong pipe, but she would have been breathing. Abdominal thrust, that's what we call it. We used to actually practice that. They don't want us practicing that anymore. But if a person does fall out, then we start CPR. That's our protocol. They call that the Heimlich Maneuver. Just keep you a flat surface and go up, in and up. Just like that stomach is a ball that you want to press all the air out of. That's how you get it to come up, because it's actually got air and gases in there that we can push out that helps then. That's why we're going to push the stomach area up and out. Shock. Number one thing to do with shock, sometimes people have been cut. Something's wrong, the blood pressure is went too low, things happen, something happens. But what we're going to do, and I want you to underline number 7, elevate the legs about 8 to 12 inches unless the person has a head, neck, back, spinal. They always got to say unless. But if they've got some broken parts in their back or neck. But elevate the legs about 8 to 12 inches. That's important. Make sure that's underlined. Know what a myocardial infarction is. That's a fancy way. Myo meaning muscle, cardio meaning heart. So it is an infarction of the heart muscle. That means a heart attack. That means it kills the heart. And that's what a heart attack is. Some part of your heart's not getting its oxygen and it dies. And that's what your heart attack is. Now, a lot of times they cause severe pain. I've actually had that feeling, but it was my spleen. So all your little organs in here have weird little places where pain will be felt. Mine actually was the same thing. I felt it in my arm, felt it down my arm. It never got to my chest, my neck, but I felt it, lower neck I should say, but it never got up. But I felt that. I felt like I couldn't breathe. It was like I had punctured my lungs. It was not, there was nothing wrong with my lungs, but I could not breathe. It hurt so bad to breathe. And it's probably the blood that was in there that was in the wrong place. Anything in the wrong place is going to hurt like heck. And plus, that's probably it's like poison. Anything that gets into the wrong areas, anybody burns and hurts bad. And appendicitis, that's one of them too, that hurt. But I felt that pain. So I know what pain they're talking about. And it felt it in my arm. But heart is just the same. That pain in the heart, women have weird places. They feel it in their back. They have, some people have weird throwing up spells. They're like, why are you throwing up? And next thing you know, they're having a heart attack. It's weird stuff that happens to people. Difficulty breathing is one of them. Dyspnea, DYS, means difficulty. Apnea means breathing. So difficulty breathing. They can go bluish or gray. Just because they're not getting oxygen where it needs to go. But that is what a heart attack means. It means somebody, and they describe it, something sitting on my chest, it's hurting, it's killing me. Responding to a heart attack. We can't do a lot as a CNA, or even as a nurse. We're going to start putting meds in there, but the doctor's got to come and tell us what to do, really. But we can start. But as a CNA, loosen the clothing around a person's neck, underline that. Because what's going to happen next, we might have to intubate them, or we may, they're going to feel like I felt, like they can't breathe, and they're going to be breathing like, not a thing is wrong with their lungs. It just feels like it. But loosen the clothing around the person's neck, so underline that. If someone's bleeding, y'all should know this, what you do?
Put pressure on it.
Put pressure on it. Do you lift up and look and see if it stopped bleeding?
No.
No, you leave it there. You want to keep it the cleanest thing against their skin. If you can find something, the cleanest thing needs to go first. If you can't find anything, you get what you can. Just make sure that you are closing that wound. Wounds can be bad. If it's an artery, you're really going to have to hold that pressure and not let it go. Veins tend to clot faster, but an artery, you're going to have to beat the part of the artery that's missing. So, or you know, whatever you covered it, that you're actually doing that. So make sure you're holding that. Harder to clot for an artery, much harder than it is for a vein. Know that as well. Burns. Know the difference in these two type of burns. You've got your page 40. You got your minor burn, and underline, use cool, clean water. For a minor burn, cool, clean water. For a more serious burn, you actually just want to cover it, but do not use any type of ointment, water, salve, or grease on a major burn. We're pretty much, even as nurses, we might slap some ointment on it and throw you in some sterile type dressing and wait till the burn center comes, because those are special. When you get a big burn, they're going to take you to the burn center, because things happen when you don't have the barrier to your body that you just burn off. I mean, things start leaking out. If you've ever seen a real burn patient, they swell up like they've been soaked in water, because that's just happens. They have to eat certain foods. They have to eat twice much as nutrients. They can't eat half of them. They're putting it through their body, because their body like turns up metabolism like 2 times, because your body is messed up. It ain't got its barrier. We need the skin. When you don't have that skin, it acts up. If somebody faints, what do? If they think they're fainting, first thing you would do, we talked a little bit about blood pressure, low blood pressure. Put their head between the legs, or just tell them, at least do this. And you'll even feel, you can do this right here, and you can feel the pressure to your head. That's blood, more blood flowing to your head. So get them to do that, and maybe they won't faint. If they do, most of the time they are revived within 15 minutes. If they fail, you leave them on the floor and call a nurse, tell them this person failed, they need evaluated before you pick them up. But most people that faint just come right back. Insulin reaction, you got to know the difference in these two. Insulin reaction and diabetic ketoacidosis. So, just in general, you know definitions, you know words. If I'm having a reaction to insulin, does that mean I have insulin? Yes. Use that when you're trying to figure out the differences. So if I have an insulin reaction, that means I have insulin.
Oh, yeah.
And that means I probably got too much, or I didn't eat enough. So underline that part. Insulin reaction or hypoglycemia can result from either too much insulin or too little food. You got to know the difference in those. And I always remembered that. And then I knew the other was opposite, ketoacidosis. And then underline that. It's hyperglycemia caused by having too little insulin or too much food, too much calories, too much carbohydrates. You can have diabetic ketoacidosis. And that's normally it's something severe. They let it stay high and haven't got treated. Some diabetics, they go high and they take their insulin and go back down. That's not how it should be. It should always be at a level. And I can't stand the ones, and I'm always trying to tell them, Okay, you about to eat some ice cream, your sugar level's gonna go to 700, so then you're gonna go take your insulin to cover that. And that's not, anytime your blood sugar goes above a certain level, you're causing damage to your body. So we don't want that. We want it steady. If you think you're gonna eat a chocolate shake, while you done ordered the chocolate shake, give yourself some insulin, so it never goes up. And you learn your body if you know your body. And that's so many teenagers, they got the little thing. Have y'all seen that? They'll dial in the carbohydrates. They'll say, well, I got a potato, I got a sandwich, or whatever they're eating. Hopefully they're not eating like that, but they will dial the potatoes, 3 carbohydrates, that's the 2 pieces of bread, that's 1 carbohydrate, and they give themselves their insulin. And once they learn, and I commend them because they know, like, they know how much carbohydrates in a cucumber. They really do, because they've had to live with it. And life or death for them. So they learn. Or they end up in the hospital and they don't like the hospital, so they learn. But that's your differences. Know your differences. For insulin reaction, that means you have the insulin. So you've got too much or you didn't eat enough. And then your diabetic is opposite. They call it DKA. Underline right up under there too, when you have a high blood sugar or DKA, it's characterized by increased thirst or urination or abdominal pain, deep labor breathing, and your breath may smell sweet. But especially that thirst and urination, your body is a wonderful thing. You got too much sugar, you're causing damage somewhere. Your body says, okay, I got too much sugar, and it turns on this little mechanism that says you are thirsty. So you start drinking, so you can flush that sugar out. And that's what your body's literally trying to do, to get you to drink some more water, or hopefully it's water, because that's what it feels. And if somebody ever says that, all I'm doing is drinking water, my mouth's dry, and you ought to tell them to check their sugar, because a lot of times that's what it is. And it's high, and your body just naturally tries to get it out, and that's how it's trying to get it out.
I drink so much, go to the bathroom so much, they have me checked like 4 or 5 times when I was little.
Yeah, and that's why, because that's your sign, and that's what it is. But know the difference. If you don't have enough insulin, you're gonna feel weak. You're gonna be clammy. You're gonna be drowsy, confused. You can get that with diabetic. You actually can go a lot higher than you think and still be just talking and being normal. It's not that it's not causing damage in the littlest bitty veins in your body, because it is. But it doesn't cause as much damage as no blood sugar. Your brain lives on sugar, carbohydrates. And broken down, that's what we use for brain of the food. Brain food. Food, y'all know what I mean. But you get real confused. If you ever had some low blood sugar and you get tired, and you get too low, you're going to get confused. And that is your sure signs of insulin reaction or too much insulin. Know all of those symptoms. Then you got seizures. Our number one thing for seizures is keep the resident safe. Underline that. That's second sentence. Should be resident is safe. Because we can't do a lot. Even your nurses can't do a lot. We can give them some muscle relaxant to help ease it. Once it's in there, it takes.
Muscle relaxer good?
Yeah. Ativan. We get Ativan. And that helps break it. But we don't. Seizures are terrible, and I hate to see somebody having a seizure when we can't do nothing. And hopefully you're at a facility that has Ativan or something laying around, so we can give them some, because that's going to help break it. And when the ER gets here, they're going to try to see if they was on any medication, or is their seizure medication too low. They're going to pump some Dilantin in them, and that's seizure medication. And hopefully they'll get them on out of there. And because a lot of times you'll see younger people, they stop taking their meds. I ain't had a seizure in 2 years. Okay. And they stop taking their meds thinking they're cured. And they say, here they go having seizures. So just know, hopefully they'll be able to tell you then. And our job is to keep them safe. Huh?
How many different types of seizures really?
We've got 1, 2, 3, 4 maybe. You got the very small ones. They call them petite or focal, partial. They kind of run all together, but we describe them different. Partial would be not all their body. The one that's focal is they're probably just sitting still, they're not doing nothing. The children kind of get that a lot, and they kind of grow out of it. But a lot of times the telltale sign that they've had a seizure, they be so tired afterwards. They just be tired. If they get up and act like that and then run up and down the street, they probably didn't have a seizure. And they think they've been cured. I doubt that was a seizure because they're going to be tired. It's all your synapses in your brain
Well, my youngest
messing up.
until he was 3, but like it was like every muscle in his body constricted and he stopped breathing.
Oh yeah, that
And then
is
he'd sleep for like
grand mal. That's what
3
we call
hours.
them. Yes, and that's grand mal. That's the big ones. That's the big ones, and that's the ones that we worry about because that's what it can cause. And I'm so worried about that, and I'm always checking their airway. Even if I can't, sometimes they're shaking so hard, I still get an O2 sat on them and try my best to get a good one. As long as I see some numbers up there, I'm happy because a lot of times it will close off their airway as well.
I think people live.
And I just, I know you were scared, baby. What they gave you? What they gave him to get out of it?
Nothing.
Oh God.
I can get my knuckles and run them up down his backbone.
Yeah, and push them real hard right here. They say
I guess
that'll
the
get you.
pediatrician saw him have one. And
I don't like it. If they
They never
continue
gave me
back and
anything.
back, take him to the ER and get him some seizure medications
They never gave
to
me
block
anything.
him out.
Well, he's had CT head scans.
Yeah.
And
They don't see
nothing ever
anything.
showed anything.
They sometimes grow out of it. I want them to grow out of it. How old is he?
He started,
13.
he didn't have one in 2 years.
Okay. Sometimes they grow right on out of it.
It started when he was playing with my mop and he hit a chalkboard I had hanging in my kitchen and it hit him right across here and knocked him out.
Yep.
And
That's
then
probably where it's coming from.
that he had him until he was like a year and a half old when that happened. And he had him
That's
till-
how a lot of them come. They've been some kind of head injury.
But we
Dang.
went to specialists, neuro specialists. and
So
all
they
that
didn't
stuff,
see
and all
swelling. They didn't see anything growing. I mean, it might be just as simple as some
that.
fluids in the wrong place.
And we went through all kinds of stuff. They never, nothing ever showed.
Yeah, I know
Thank
it
God,
is.
but
Amen. Did they have him on seizure medication or they just let him go? Yeah, that's what they're thinking, that he's gonna grow out of it. And I hope he does. I hope he stays seizure free. Amen. CVA or stroke. That is your cerebral vascular accident. You will need to know that. It occurs when brain or blood supply to part of the brain is blocked or blood vessel leaks or ruptures. So that's your aneurysms in your brain. Or something, and I call it, your plumbing that bursted in your brain. Or a clot and it stopped the flow. So that's the 2 different kind of things you can have. They're both going to call them a CVA, cerebral vascular accident. And that's the worst case is the stroke. Sometimes you have a transient ischemic attack, which is the same, but it's like it went through, but it did not. It can cause damage because you're blocking your blood flow to your brain, but it kind of comes back. A lot of people, sometimes they can't talk, sometimes they can't move some other part of, but they call them the partial seizures. And not seizures, but strokes or mini strokes is what a lot of people call them. But that's what they are, transient ischemia. It's kind of went through, caused a little damage, but they survived, or most of the time it's just small damage.